Okay, so took my little break. We finished up to question 25 of the first block, so that's half the first block. And then right now I'm going to wrap up the other half of the first block of questions. Okay. Okay. So 26. Alright, let's get this going. 26. Following a wedding reception that was attended by 75 people, 25 adults developed low-grade fever, abdominal cramping, vomiting, and diarrhea. The symptoms begin 24 to 36 hours after the event and resolve without treatment in 3 to 4 days. Studies of stool specimens from several of the patients show no occult blood, no leukocytes are seen in microscopic exam, and stool cultures show no pathogens. Several family members exhibit similar symptoms 3 days after the initial outbreak, which of the following is the most likely causal organism. Now, microbiology, right, when you finish studying microbiology with sketchy micro or whatever, the latter half of that microbiology section has the study of systems, right? And that's something you really want to focus a lot of time on for mastering microbiology. So when they have the systems part, this thing, right? Because then you're going to see like bugs that cause diarrhea, and you need to know the difference between that. Then you have common causes of pneumonia, common causes of meningitis, and so on and so on. And you need to associate each one of those things with the number one cause in different ages, the number one cause in different genders, etc., etc. So when you look at diarrhea, right, there's a lot of guys that cause it, and when you look at each one of them in their own specific page in first aid, you get to see how they all occur. So they give you a lot of information here. First, it's self-resolved. Second of all, they were all on attending a wedding. They were all at a wedding reception, right? The symptoms began after a day. So 24 to 36 hours later is when everything began. It didn't begin immediately. So I tell you right here, the speed of onset, lack of blood, lack of pathogens, and self-resolving nature all depict that this is a viral gastroenteritis, right? That much was very obvious, because if it was a bacterial one, they would find pathogens. It would not necessarily self-resolve. You would need antibiotics, and so on. The norovirus is a positive RNA calicivirus that causes outbreaks commonly on cruises, leading to watery diarrhea. It is mainly transmitted via shellfish and can have concomitant hepatitis A infection. Its incubation can take 1 to 2 days, and it self-resolves. Rotavirus is a double-stranded RNA, reoviridae or repidoviridae. That's how you remember rotaviruses too. And that most commonly causes infantile gastroenteritis, but most people are vaccinated. Staph aureus is a bacteria, so you can cancel that answer out. Shigella dysentery you can also cancel out, and it would cause bloody diarrhea. The others can cause blood, and bacteria would show up as pathogens. So that's kind of how you cancel out all the other answer choices. So norovirus, you're supposed to remember it by the narwhal, which is a kind of like a big-ass whale in a sense. And it comes from this sketchy micro image here. So that big guy right there, that's your norovirus thing. And this is the dragon from Khaleesi's dragon, or Game of Thrones and stuff. So that's kind of how you're supposed to remember this. And it's most commonly seen on a cruise. And this propeller, you know, with all this water blowing from it, this looks like really explosive diarrhea with no blood, right? There's no red stool anywhere. No one's sitting on a red stool. So it causes just diarrhea, plain diarrhea without the bloody aspect, and it's viral. It's a naked virus. That's why you have the naked statue of David here. And it's sunny, right? So it's a positive, right? The sunlight makes a positive sign, so it's a positive virus right there, and that's what we're seeing here. So we're looking at calicivirus, norovirus, viral gastroenteritis, right? Positive RNA virus. So sketchy is probably the best way to memorize any bugs in general, as I said earlier in the last video too, and they do a great job in making sure you can master it all. So that was it for this question. This is slightly difficult of a question, especially if you don't feel comfortable with microbiology. So micro and biochem are two things that you have to visit multiple times, keep revisiting over and over until you finally feel extremely comfortable with topics. This one here, 27. An investigator compares the DNA sequences of a group of newborns with achondroplasia with the sequence of a group of healthy newborns. DNA sequence analysis shows a G to C mutation in the fibroblast growth factor 3 receptor gene on chromosome 4. The sequences for the two groups are shown, and they tell you achondroplasia versus healthy, and you can see where the difference is. This C became a G. Okay. As a result of this mutation, an MSPI restriction enzyme site is created that allows for a convenient diagnostic test. Which of the following sequences most likely represents the substrate specificity of MSPI? So basically what they're asking you is, how would you make these restriction enzymes? What would the restriction enzyme be looking for? And if you look at answer choice D, it has the CCGG right here, 5' CCGG, which would really attach to this portion right here. The two C's would hit the two G's right there, and so on, right? CCGG, palindrome. It's a palindrome. It's a palindromic sequence in that matter. Most restriction enzymes bind palindromes, and 5' CCGG or 3' GGCC would both be acceptable answers here to bind the underlined segment, right? Because this here is 5' CCGG, so if you have this 5' CCGG like that, it can bind the other half, right? Palindromic sequences are a really easy thing that you can get questions on. You want to make sure you don't mess that up. If you had no idea about that, then you could really just figure out which one of these guys would stick to this area. Right, because that's how you're going to identify it. You want to make a restriction enzyme that just sticks to this area where the mistake is, and it's really just that one. The others won't necessarily stick to this 4 sequence thing in the middle where the error is. 28. Okay, 28 was an interesting question. A lot of students I worked with did get this wrong. So a female newborn delivered at 36 weeks gestation is in respiratory distress. Very common thing, okay? And pretty high yield topic on tests. APGAR scores are 3 and 5 and at 1 and 5 minutes, respectively. Physical exam shows cyanosis. Endotracheal and nasogastric tubes are placed. The X-ray shown depicts the nasogastric tube in the left hemithorax, displacement of the mediastinum to the right, and absence of bowel gas in the abdomen. This condition most likely results from which of the following embryologic events? Right, and the correct answer here was incomplete formation of pleuroperitoneal membrane, but that's actually a little sentence that you probably read in first aid and completely overlooked. So if you look at all the other answer choices, you're supposed to be able to still figure this out. If you look at the X-ray they show you, first thing you notice is that everything has the same color, the top and below, right? Above and below the diaphragm, you're seeing the same color. And that's pretty bad. That's not supposed to happen. There should be air in some places. The next thing is this tube actually came like this and then twisted this way. Right? Twisted this way. But it should have kept going down and gone into here. So it twisting this way on the left means that somehow gastric contents have come up to here on the left and not the right, because the right has the liver protecting. So this patient has a congenital diaphragmatic hernia causing abdominal contents to pop up in the left thorax, since the right is safe thanks to the liver. The lungs get compressed, leading to hypoplasia, which is why this baby has respiratory distress. This is due to D and can also be due to trauma, right? Incomplete formation of the pleuroperitoneal membrane. Choices A and B are embryology related. The myotome is divided into two sections, the epimeter and the hypomere, and that's what they're talking about here. This is not discussed in first aid at all. Kaplan talks about it. Epimeter and hypomere, which form the epaxial and hypaxial muscles. They make muscles. That's what these guys are for, and this is not a question about muscle issues. The epaxial muscles are the erector spinae and small intervertebral muscles, and the hypaxial muscles are everything else, including those of the limbs innervated by ventral rami. Okay, so that's what the epimeter and hypomere are for. Hypoplasia of the lungs is what a lot of people picked, and this is not a question about that. That's not what's happening here. The nasogastric tube would not be necessary to figure out hypoplasia of the lungs. So we go to page 401 over here in my PDF, and we can see, well, these are just normal hernias actually. Hold on. Yeah, so it's not a hiatal hernia that this baby has. The baby has a diaphragmatic hernia like this. You see how all the contents from here really came up into up here. Okay, and that's the issue that the baby is having. Okay, so that's something you want to watch out for. Compare that to respiratory issues. If you look at respiratory embryology, yeah, this thing, right? Pulmonary hypoplasia, that's different. You see, and here this is what what we're kind of seeing with the baby that we have in our question. Literally like that. That's what we're seeing. But it's not a question about pulmonary hypoplasia per se, right? Hypoplasia of the lungs. For one thing, this answer choice can really be ruled out because it's saying hypoplasia of both lungs, and it's not necessary that both lungs do have hypoplasia. But something like this is what's happening, right? The small intestine moved into the chest cavity. The baby has a congenital diaphragmatic hernia. Pulmonary hypoplasia is poorly developed bronchial tree with abnormal histology and can be associated with congenital diaphragmatic hernias, usually left-sided like that. Right? So putting both things there were fair to do because the two are, although related, completely different. They're related but different. This is not just a case of hypoplasia of the lungs. It's hypoplasia of the lungs secondary to something else. And the main issue was incomplete formation of the pleuroperitoneal membrane, which they do talk about. I'm pretty sure they mentioned it right here. Yeah, right here. See, pleuroperitoneal membrane. Abdominal structures enter the thorax and may occur due to congenital defect of pleuroperitoneal membrane or from trauma. Okay, so this was just a diaphragmatic hernia, which then caused hypoplasia of the lungs. 29, an 82-year-old woman. So again, remember, anytime an age above 65 is mentioned, you want to think of something where someone is way, way old, right? 82-year-old woman is brought to the physician because of a 1-week history of episodes of lightheadedness and fainting. She has hypertension, currently treated with propranolol. Her pulse is 45 per minute, and blood pressure is 90/50. So propranolol is a beta blocker, and her pulse is really low, so she shouldn't be on a beta blocker in that case. That's something you want to catch right away. Physical exam shows no other abnormalities. ECG shows normal regular P waves followed by normal QRS complexes. So she's not having arrhythmia. The physician the physician decreases the dose of propranolol. 5 days later, the patient's pulse is 80 per minute, and her symptoms have resolved. Great. Which of the following is the most likely explanation for this patient's low pulse while taking the higher dose of propranolol? Okay, so you look at each answer choice. Decreased activation of fast sodium channels, decreased rate of repolarization, decreased slope, blah, blah, blah. So these are all questions asking you about exactly what this thing does when you go to cardiovascular pharmacology. And we talked about cardiovascular pharmacology already. That's already on the playlist. So this image from AMBOSS was the main summary of everything, right? Class 1A, 1B, 1C, 2, 3, and 4. Right, you know that 1A, 1C, 3, and 4 antiarrhythmics prolong the effective refractory period. 1A and 3, except amiodarone, also prolong the QT interval. Those are main key points you want to watch out for. But the main thing here, you know, we're using a beta blockers. Now, you need to remember which one is which. And when we look at beta blockers, that's the class 2. Right? Class 2 is your beta blocker. Right? This one right here. You can see that the beta blocker, all it really does is it decreases the slope of phase 4 depolarization. So you have a prolonged repolarization, and your heart rate pretty much slows down. So beta blockers work by decreasing cyclic AMP and calcium, thereby slowing the SA and AV node activity. This prolongs phase 4 of depolarization, right? Decreased slope of diastolic depolarization. Therefore, they are known to increase the duration of diastole, causing both a rise in heart coronary perfusion and reduction in heart rate, which is great. You slow down the heart rate so that more blood stays in the heart and you get more blood to the coronary stuff. Remember that your own heart gets itself blood during diastole. Remember, because when your heart contracts, blood goes from your left ventricle into the aorta, into your body. And then when it's diastole and your aortic valve closes, the blood that comes back down onto the closed aortic valve is then able to enter the coronary vessels. So you give your own heart blood during diastole, which is really important to remember. That's a really good physiology right there. So each one of these, though, when you read them, you should have been able to associate a medication to. So if you can't, that's something you want to go ahead and practice for yourself and do. That's an active form of studying, right? So you should know what causes decreased activation of fast sodium channels, what causes a decreased rate of repolarization phase, and so on and so on. And some of these might not even be real. Okay, but propranolol is a beta blocker, and you need to know each one of them. You need to know how they all work. Each one of them, 1A, 1B, and 1C. When we talked about it in my cardiovascular videos, I said that 1A looks like someone pushed it from this side, so you can see how everything tilted over towards the right. 1B, someone pushed it back, so now it's stuck in between. And then 1C, someone again pushed, it's like a tug of war, but the right side is fixed correctly, it's just pushing from here. So that's all, the pushing is all about depolarization versus repolarization. You need to know depolarization or repolarization. Is the pink area affected or the green area or both? And this is color coded really well. So the same depolarization, repolarization stuff is also associated with the color coding here for the AV nodal stuff. Beta blockers in class 4. Alright, class 3 is the potassium one, and potassium is always about repolarization. So if you block that, you block repolarization, and that just makes repolarization take forever. That's it. Alright, so really good stuff to review. Always want to make sure you come back to things when you do questions like this. Number 30 says a 30-year-old man comes to the physician because of a 3-month history of pain in his jaw and left arm. He also has had intense thirst and increased urination during this period. He was found to have peptic ulcer disease 2 months ago. Physical exam shows no abnormalities. Serum studies show a calcium concentration of 13.5 and an intact PTH concentration of 110. So PTH is very high. An X-ray of the left humerus shows no abnormalities. Which of the following biologic mechanisms best explains the impaired calcium homeostasis in this patient? Okay. So if you look at all the answer choices, because you're trying to figure out what's wrong with this patient. He's got pain in his jaw, pain in his left arm, right? Increased urination, peptic ulcer disease as a history 2 months ago. Calcium of 13.5, PTH high. So why would PTH be high? So now you're trying to you have to remember that graph of PTH versus calcium and associate one of those things with this patient. What is wrong with this 30-year-old man? Where the x-ray is fine. His bone is not necessarily all being ripped off. So this patient has primary hyperparathyroidism being caused by some kind of parathyroid adenoma. Addition of the peptic ulcers suggests Zollinger-Ellison as well, and now you're starting to think this must be men 1. But none of that is really important here because that's not what they're asking about. All they're asking for is the function of PTH, right? Which of the following biologic mechanisms best explains the impaired calcium homeostasis? Well, the calcium homeostasis is impaired because he has too much PTH. What does PTH do? Well, PTH increases osteoclast maturation and activity. In general, PTH increases osteoclast activity. All right. PTH promotes osteoclast activity of breaking bone hydroxyapatite into calcium and phosphate. But osteoclasts do not have a PTH receptor. PTH actually binds osteoblasts, which then secrete rank ligand to bind rank receptors in osteoclasts and activate them. All right. So you have to find the correct answer, and any of that could have been the correct answer here. But recognizing that this is men 1 is significant for us as students trying to study this because you definitely get a lot of questions on men. It's possible to get up to 2 questions for sure on your own step 1 regarding men's syndrome, so you don't want to mess that up. You can even get 3, to be honest, because men's syndrome is a really good thing to make questions on. It's really easy to make complex questions on it. 31, an 18-year-old woman comes to the physician because she never had a menstrual period. Physical exam shows a 1 centimeter invagination where the vagina would normally be present. No uterus is palpable on rectal exam. Lab studies of serum show FSH is 8.3, LH is 6.7, estradiol is normal, and testosterone is also normal. So which of the following structures is most likely normal in this patient? That's all they want to know. What must be normal in this patient? So would this patient have a cervix, a ductus deferens, ovaries, the round ligament, testes, or a uterus? Well, they told you, right, that she doesn't even have a vagina, right? She has, this 18-year-old woman has an invagination where the vagina would be. They tell you no uterus is palpable on rectal exam, so you can cancel out answer choice F. And without the uterus, you can kind of also cancel out D, round ligament, kind of called the round ligament of the uterus. Now, would she have testes or ovaries? Would she have ductus deferens and cervix? When you look at all these answer choices, right, consider this. When you see all these answer choices and the fact that ovaries and testes are both here as answer choices, one of those 2 things must be normal for this patient. So you're really just down to C and E. That's the first thing you want to understand in terms of logical thinking. Because they put both answer choices here, ovaries and testes, one of those must be normal because she has normal amounts of estradiol and testosterone. So now you gotta figure out what's wrong with her. 18-year-old woman, 1 centimeter imagination where the vagina would be, and then you have to start thinking of the reproductive tree and how Mullerian inhibiting factor works and how the SARI gene works from the Y chromosome. This patient has Mullerian agenesis. So the answer was C. Ovaries must be normal in this woman. The Mullerian paramesonephric duct becomes the female internal structures, right? That thing gives you the fallopian tube, uterus, and upper vagina. The lower portion comes from the urogenital sinus. Mayer-Rokitansky-Kuster-Hauser syndrome, the longer weird name that they gave, presents with primary amenorrhea due to the lack of a uterus in females with full secondary sexual characteristics thanks to functional ovaries. Okay, they didn't tell you that. They didn't tell you that she has good secondary sexual characteristics, that she's developing physically like a woman just fine, but they did tell you that her estradiol is pretty much normal, at which point you could automatically think ovaries must be fine. This Mullerian agenesis is often compared to androgen insensitivity, where the LH and testosterone will be high due to a lack of negative feedback because you have androgen insensitivity. And the patient will have no pubic hair and androgen insensitivity. That's one of the major things. So 46XY male will appear as a female with female external genitalia, a rudimentary vagina, but no uterus or fallopian tubes, just like this 18-year-old woman. These patients will have normal functioning testes in the labia majora. See, and that's the other half of this question. And they must be surgically removed in the case of malignancy. So two different spectra here, right? We got a question on Mullerian agenesis in number 31, but another question could have had the same exact patient. At this time, LH and testosterone would be slightly high, and the correct answer would be testes. This patient would have normal functioning testes. They would just be in the labia majora, and they need to be removed because it's the risk of getting testicle cancer at that point. So if we go to page 677, which is actually 608 in FA 2019, you get to see that. You get to see your Mullerian duct, Mullerian agenesis, which also is called this long name. Right? With Mullerian agenesis, you get primary amenorrhea because you don't have a uterine development. Right? But the secondary sexual characteristics are going to be just fine. Right? And then you need to know this tree. You need to know this tree really well for sexual differentiation, because different issues along this tree will lead to different issues when you go to the reproductive pathology. Right, so when you go to the second page of reproductive pathology, you get this diagnosing disorders of sex hormones and other disorders of sexual development. It comes from that tree, so you need to know that tree of development really, really well from that page. Okay? But that question wasn't so bad at all. 27-year-old woman comes to the physician because of a 3-month history of intermittent headaches and palpitations. Her initial blood pressure is 125/80 while she sits in a chair. When asked to sit on an examination table, she has facial flushing and her blood pressure increases to 185. Physical exam shows no other abnormalities. Which of the following is the most likely diagnosis? So that's all they gave you. This is all they gave you, right? And then you look at your answer choices, you see a lot of things. Coarctation of the aorta, a lot of people thought that might be the answer. Hyperthyroidism, pheochromocytoma, primary aldosteronism, and renal vascular hypertension. Now, you can immediately remove renal vascular hypertension because in that, the blood pressure would just be high all the time. That's it. It would just be high, like constantly. Similarly, in coarctation of the aorta, remember how coarctation of the aorta affected the aorta? So it affected like 1/2. So you would have different blood pressures in different hands. That's not what they're showing you here. You can cancel out A. Hyperthyroidism, if it's going to cause blood pressure issues, that would also be constant. It's not something that would change. Same thing with primary aldosteronism. If you have too much aldosterone, you're going to have high blood pressure. That's not going to change. What I'm trying to say is that in all of those answer choices, your blood pressure would stay high, and that's it. It's not going to be low at one point and then high at another point. So the only plausible answer choice you could have chosen was pheochromocytoma, where you have remitting moments of high blood pressure, right? This is a very unorthodox question scenario, but the other choices do not fit at all. Coarctation of the aorta would have brachiofemoral delay with increased risk of barrier aneurysms, both due to increased blood flow to the head. Hyperthyroidism does not cause this, neither does aldosteronism, right? Both of those would cause constant blood pressure elevation. And renal vascular hypertension would just have hypertension, not the flushing part. This patient has a normal blood pressure initially because Pheos have a relapsing pattern. When people stand up, a lot of sympathetic things fire off. And with Pheos, you already have high amounts of sympathetic things. So when she stood up and tried to get on an examination table, the extra sympathetic stuff made her even more hypertensive. And that's all that really happened here. Really weird way to test you on that, but it is what it is. NBME gets away with asking you really, really retarded questions. So, coarctation of the aorta right here, right? Brachial femoral delay, because what happens, depending on where it is, depending on where the coarctation occurs, right, and depending on the type of coarctation you get, you're gonna have this collateral blood supply under your ribs, so you start seeing nib rotching, and then, I said you're gonna have different blood pressures in different hands. That's not what happens here, my bad. You're not going to have different blood pressures in different hands. You're going to have a difference in blood pressures in your arms versus your legs, because your aorta supplies both arms just fine, but then the descending aorta is not getting enough blood, right? So that's the brachial femoral delay, not different blood pressures in your different hands. So did I have the right thing written here? Yeah, I have the right thing written here. Okay. So just make sure you get that right. But other than that, the fact that her blood pressure was changing was the main thing. Alright, so that's 32. Just a weird, confusing question. This is a question that a couple students that I worked with apparently saw a question like this on UWorld. I've actually never seen the UWorld version of this question, so if anyone has it, I would love to see that question if you could just email it to me. But this was a question that a lot of students found very difficult to actually grasp, even after I explained it. So let's take a look. Purified serum antibodies elicited by immunization with protein X are adsorbed to microtiter wells. So already when you read that first sentence, you're like, oh fuck, what are they going to ask here? You're already seeing a graph that doesn't make sense. The graph shows the amount of radiolabeled protein X that is bound by the solid phase anti-X antibodies in the presence of varying concentrations of protein Y. So we're seeing how much of the antibody is bound to X while you're adding Y, right? And that's how you're supposed to read the graph. So with respect to the anti-X serum, which of the following interpretations regarding the epitopes expressing proteins X and Y is correct? So what they're saying is amount of labeled X that is bound is decreasing as you add more Y. So the antibody was bound to X, it stopped binding X, and then it started binding Y, right? It must have. That's the only reason it would stop binding X. So if some antibody was attacking protein X, stopped attacking protein X, and then started attacking protein Y because you're adding a shit ton more of protein Y now, that means that the two proteins must be very similar. That's because antibodies are pretty specific. So you would go with answer A. Proteins X and Y express the same epitopes. That's it. Other variations of this question would be that if they gave you a graph where you had this line, right? So as I'm adding Y, the more Y I add, there's really no effect. Antibody is staying stuck on X. That means that the antibody is not leaving X to go attack Y, which means that X and Y must be very different epitopes, right? So that would be answer choice B. Answer choice B would be related to the red line. Protein X expresses all of the epitopes expressed by protein Y, but protein Y does not express all the epitopes expressed by protein X. Is a weird thing that you cannot explain by a graph. You can't. Okay, you're basically saying that X has, this is kind of mathematical. Remember that in math, a rectangle and a square, you can make a sentence about that and say that a square, a rectangle is, a square is a rectangle, but a rectangle is not a square, right? A square fulfills all the requirements you have to be a rectangle, but a rectangle does not fulfill all the requirements to be a square. Right, so that's kind of what answer choices C and D are saying. That protein X has everything that Y has, but Y does not have everything that X has. Y has more things. Right, and that kind of difference doesn't really it's not something you can represent on a graph. But this red line is the other answer choice you could have for the answer to be B, where they have no similar epitopes. So adding Y did not make the antibody get off, and that's really all that's happening here. All right. Let's see now. 34. A patient with a 1-week history of diarrhea has reduced tissue turgor. Arterial pH is 7.3. Serum bicarbonate is 15. Patient is also likely to have which of the following? Decreased PCO2, decreased circulating ADH, decreased aldosterone, increased ANP, and increased serum anion gap. So increased anion gap would be the mud piles things, right? But all they tell you here is that this patient has diarrhea. Right? Patient with a 1-week, they don't even tell you the age of the patient, just a patient with a 1-week diarrhea. pH is 7.3, bicarb is 15. So this patient has a low pH and a low bicarb. The chronic diarrhea will be compensated by respiratory hyperventilation, leading to decreased CO2. Adrenal insufficiency has low sodium and bicarbonate, leading to metabolic acidosis. The bicarbonate chloride exchanger increases chloride in exchange for bicarbonate, and potassium and H will be high as well. So you end up getting high NaHCO3, high sodium, high H, high bicarbonate, but low HKCl. All of that decreases. And this is not adrenal insufficiency, because that's kind of what the other answer choices made. Those other answer choices are actually all related to adrenal insufficiency. In adrenal insufficiency, where you don't have aldosterone, your sodium and bicarbonate will be high, your H+, your K+, and your chloride will be low. And that's not what's happening to this patient. This patient is just having diarrhea, pH is low, so that's very clearly acidic. Bicarbonate is also low. Remember, it was about, let's take a look at the acid-base physiology stuff, page 643. So that's, I have it labeled anyway. Yeah, right here. So when you look at, you have to remember what's normal, and you have to remember the bicarb 28, 36 to 44 for CO2, and 7.35 to 7.45 for pH. Now, this patient, first of all, this question didn't really give you enough information, but you could still figure the answer out. Anyone that's presenting with diarrhea, and then they have low pH and low bicarbonate, you can look at the chart, right? If you have low pH and low bicarbonate, you must have low PCO2, as the hyperventilation immediately occurs to kind of balance off the acidosis. You breathe it all out. In general, what you're thinking here is if you have acidosis, you must be hyperventilating to get rid of the CO2 to fix the acidosis, because clearly the bicarbonate here is not going to fix the acidosis, right? That's one way to think about it in this question. Bicarbonate usually can fix acidosis because bicarb is alkaline, but this patient also has low bicarbonate because of the diarrhea, So that's where you start hyperventilating. So this was a metabolic acidosis related to this first column right up here. That's what happened here. But you can see how Addison and Kahn are also something that can be used as confusing answer choices. Of the two, Addison being the one that causes metabolic acidosis, right? If you have no aldosterone, you lose sodium and you keep potassium and H+. If you're going to keep H+, you must be losing the bicarbonate. If you're losing bicarbonate, that means you're keeping chloride via the basolateral bicarbonate chloride exchanger in your PCT of the kidney. So in essence, you end up having metabolic acidosis with the low sodium and bicarbonate and high potassium chloride and H+. Right, so think lose sodium bicarbonate, keep HKCl. No cortisol means you have anorexia, hypoglycemia, and low blood pressure as well in Addison disease. But that is not what this patient has. That's not what this patient has. But they put some answer choices here, aldosterone and stuff like that. But that's not what this patient has. This patient simply has diarrhea. So respiratory hyperventilation will resolve try to resolve the acidosis that this patient is facing. 35. A 28-year-old man has excessive thirst and polyuria. A 28-year-old man has excessive thirst and polyuria. So as soon as you read that, you're thinking, all right, some kind of diabetes, either DM or DI. The following lab data are obtained. And then they're giving you glucose serum osmolality, urine osmolality. So this is for diabetes mellitus, and this is for diabetes insipidus. So if we take a look at everything, baseline, the serum glucose is 75, serum osmolality is 310, and urine osmolality is 175. Okay. With the 12-hour water deprivation, nothing really changes. Nothing really changes. Okay. Then they add ADH after the water deprivation, and all of a sudden, the ADH is working, right? The urine osmolality gets really high again, and this is better because you're not supposed to be urinating a lot of water, right? Osmolality means solute concentration. If osmolality is low, then your solute concentration is low because you're peeing out a lot of water, which is why this patient has thirst, right? So now, what do we learn here? Well, if we add ADH and things get better, that means that the patient has nephrogenic DI, and then you could, sorry, not nephrogen, essential DI, because the nephrogen is working, the kidney is working, right? The patient has central DI because they're not making ADH, right? Nephrogenic DI would be you add ADH and it still doesn't do anything. That means that the kidney is not responding to ADH, right? This patient, as soon as you gave them ADH, things got better. That means that they're not making ADH, so you pick answer choice D, hypothalamus. Very straightforward question. Giving ADH increased the urine osmolality. This means that ADH is not being made, but the kidney responds to ADH just fine. The baseline urine osmolality is low because you're peeing a lot of water. So the patient is thirsty. When water is deprived, nothing changes significantly, which means that it's not psychogenic polydipsia, where the serum osmolality would normalize, because in psychogenic polydipsia, everything is fine. They can make ADH, their kidney responds to ADH, they're just drinking way too much water, so they're peeing too much water. ADH is synthesized in the supraoptic nucleus of the hypothalamus, and that's why D is the answer here. And that's it. Right? Renal tubules would be the answer if even after adding ADH, there was no effect, no change. That means that the kidney is not even responding to ADH and they have nephrogenic DI. But this patient has central DI. All right. 38-year-old African-American man with recently diagnosed hypertension comes to the physician for a follow-up exam. So African-American man, okay? At his last visit 1 month ago, the patient agreed to initiate a regimen including increased physical activity, low sodium diet, and pharmacotherapy. He has had no weight loss since then. He is 175 centimeters, weighs 82 kilograms, BMI is 27, blood pressure is 150. Physical exam shows no other abnormalities. Which of the following best describes the role of ethnicity when the appropriate medication is selected for this patient? Now, this is a topic I noticed a lot of students don't actually know about, but when you come to hypertension, when you come to blood pressure medications, ethnicity actually plays a really big role here. So I wrote, the answer was E. It should play a role because the efficacy of certain classes of medications varies amongst white versus black people, right? African Americans actually do not respond to many hypertension medications. So according to UTD, it is said that for the young patient, ACE inhibitors, angiotensin receptor blockers, beta blockers are of better efficacy for primary hypertension as monotherapy. However, calcium channel blockers and thiazide are better for the elderly and black patients. Right? So if you have an African American patient who needs treatment for hypertension, you would consider a calcium channel blocker or thiazide diuretics over ACE inhibitors. Okay. Then the NCBI has this entire PubMed publication about it as well. If you want to look into that, I put that link here as well. And I think I have a note as well. Let's see, cardiovascular pharmacology, hypertension. Oh, actually, no, it's in renal. My note is in renal. Right, because when you get to renal pharmacology, that's actually heavily related to blood pressure management. So right here, I have a note. Thiazide diuretics are some of the most common agents used for treatment of primary hypertension. Use of high-dose diuretics is associated with a variety of metabolic and electrolyte complications, including hypercalcemia, hyperglycemia, blah, 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 because of the hypergluc stuff, right? Wait, this isn't the one I'm talking about, though. Where did I mention the ethnicity stuff? Oh, I guess I don't have it here. Okay, never mind. But thiazide diuretics are the one, and calcium channel blockers are the ones that you mainly use for African American patients. So they and they don't talk about that in first aid either. So you got to keep that in mind. Okay. All right. So that's that. So that's the lesson for you right there. In case you didn't know about the ethnicity relation with hypertension management, now you know. 37. A 35-year-old man comes to the physician to discuss donating a kidney to his 39-year-old sister who has type 1 diabetes and chronic renal failure. He has no history of major medical illness and physical exam shows no abnormalities. Which of the following best describes the likelihood that this donor's human leukocyte antigen type will match that of his sister? None of the students I worked with actually know about this. I'm not sure where you're supposed to learn it either, but two siblings have a 25% chance of being genotypically HLA identical, a 50% chance of being HLA haploidentical, only sharing one haplotype, and a 25% chance that they share no HLA haplotypes. So that's just a fact you need to know. And then now that you know that fact, the answer is clearly 25%, so you would just pick C. Right, the question is just asking you what are the chances that their haplotypes match entirely, and for the two of them to match entirely identical would be 25% chance. I don't know how you would know that, to be honest, or where you would learn that, but this was definitely a hard question just because of that. Really not something I knew either. Okay, 38. A male newborn is found to have a decreased blood thyroxine concentration on newborn screening. So as soon as you see something like that, you want to kind of start thinking, oh, is this about what was that disease? Skipping my mind. Anyway, physical exam shows no abnormalities. Serum studies show decreased concentration. Okay, no, I can't do that. I have to tell you what I'm thinking of because it was relevant. Let me see. Thyroid. What was that weird word? Fuck. Cretinism. Wow. As soon as I saw the picture, I remembered. All right. Congenital hyperthyroidism. So as soon as you see that it's a male newborn with decreased T4, you want to start thinking of cretinism, and you want to start looking for those symptoms of cretinism in the patient, right? With the pot belly and the tongue and all of that, right? Puffy child, protruding umbilicus, protuberant tongue, poor brain development. But then right after that, they tell you physical exam shows no abnormalities, so you kind of start leaning away from that. Serum studies show decreased concentrations of T3 and T4. His serum-free T4 and TSH are within reference range. Which of the following best explains these findings? So now this is more so a question about free versus bound T3, T4, right? This patient has decreased T3 and T4, but the free T4 and TSH are within reference range. When TSH is within reference range, that means that your thyroid concentration, your thyroid function is all fine. So it's not going to be E. You can cancel out TSH deficiency, right? You look at the other answers, maternal anti-thyroid antibodies. Well, that would kill your thyroid and your TSH would not be normal. So you can cancel that out. An organification defect in T3 and T4 would not let you have normal amounts of free T4. Okay, they tell you his serum free T4 is within reference range. It would not be if you had an organification defect. Thyroid dysgenesis would also mean that you would not have normal amounts of free T4 and you would need to have high TSH at that point. But you need to understand, because of the lab values they gave you, that this patient is making the right amounts of thyroid hormone and their TSH is normal because of that. That means that the thyroid is working, everything is okay, so the only answer you could go with is thyroid hormone binding globulin deficiency. That's it, right? That's why this serum-free T4 is fine, TSH is fine, everything's okay, he doesn't have the binding globulin. A low total but high free T4 indicates a loss of thyroid binding globulin. Bound T3 and T4 is inactive, and you can have high TBG in pregnancy and oral contraceptive use, since estrogen actually increases TBG. Alternatively, hepatic failure, steroid use, or nephrotic syndrome decrease TBG because you either didn't make it or you lost it in your urine. Thyroxine binding globulin deficiency TBG deficiency is characterized by low serum total T4 but normal free T4 and TSH. The diagnosis is confirmed by measuring TBG concentrations. These infants have normal thyroid function and do not require treatment. That's from Up to Date. So, gotta make sure you know that. That's a very simple thing that you might start feeling really confused about if you didn't really, go just logically. Just think logically. Don't freak out because it's something you haven't seen before. And then make sure logically that the answer choices make sense. Right? If TSH is normal, remember TSH is the main determining factor of hypo versus hyperthyroidism. If TSH is normal, you don't have either of those issues. That means you're making thyroid just fine. So you just pick the only answer choice that has nothing to do with the thyroid gland itself. Okay? 39. A 29-year-old man comes to the physician because of a 1-week history of fever, muscle aches, sore throat, and a non-productive cough. His temperature is 102 Fahrenheit. Rhonchi are heard on auscultation of the chest. A chest x-ray shows bronchopneumonia of the right lower lobe. Symptoms persist after 7 days of amoxicillin therapy. A test result for cold agglutinins is positive, at which point you know exactly what the problem is, right? When you have cold agglutinins and a pneumonia thing, that's walking pneumonia thanks to Mycoplasma pneumonia. And if you can't remember that, then that's actually the last bacteria, in gram-negative, I believe, yeah. Right? It's the last gram-negative bacteria, Mycoplasma pneumonia, and Sketchy Micro has this picture, right, of this referee walking, because it's walking pneumonia, right, and you have the cold agglutinins, which are causing all of this to agglutinate together. These are supposed to be your red blood cells. Alright, so that's basically all this is. And the theory here is supposed to be it's a walking pneumonia. The patient looks okay even though they have pneumonia. They're not bedridden. Right? So that's the main issue here. He's got some issues, but he's looking fine. He should be bedridden. Pneumonia is really bad. So they ask you, which of the following features of the causal organism best explains the ineffectiveness of the pharmacotherapy in this patient? Why did amoxicillin not work? Well, Mycoplasma pneumonia is a mycoplasma. Right, that thing has no peptidoglycan cell wall. Right, lack of a peptidoglycan cell wall, and that's kind of what you're supposed to see here. There's no walls. It's an open stadium. That's kind of what the image is trying to tell you. And you're supposed to use Eton agar, so don't eat on ice. Eton agar to actually grow this. Right, grows on Eton agar, agglutinates RBCs because of IgM, cold madam, so IgM. This cold agglutination IgM stuff is discussed in hematology. X-ray looks worse than the patient, right? So the patient looks okay, but the X-ray is like, yo, this patient should probably be bedridden right now. Like, how's he okay? So that's the walking pneumonia that you're supposed to see. Typically, can cause Stevens-Johnson syndrome in children and adolescents, but that's something that's pretty rare. So Mycoplasma pneumonia, the answer was A, absence of a peptidoglycan. That's it. Really straightforward. A lot of people picked alteration of the PDPs, which was wrong. Right, that would be a completely different kind of therapy, different kind of question. It can be a reason why someone might not be responding to amoxicillin, but that's not what was the reason for this patient. 40 says a 70-year-old man has a 3-month history of weakness and a 22-pound weight loss. He smoked 2 packs of cigarettes daily for 50 years. An X-ray of the chest shows a 4-centimeter lesion in the right upper lobe. Serum calcium concentrations at 13.5, no bone metastases. A malignant lesion arising in a segmental bronchus is seen during lobectomy. Which of the following is the most likely diagnosis? So when you look at all the answer choices, you know this guy has lung cancer, and they tell you serum concentration of calcium is 13.5, right? No bone metastases. What are you going to pick? So you need to remember this is either going to be small versus squamous cell carcinoma of the lung. And those two guys make different things occur. This guy has squamous cell carcinoma. He has a characteristic lesion of squamous cell carcinoma, and the PTH-related peptide is what's causing hypercalcemia. Okay? PTH is made by the squamous cell carcinoma. Small cell carcinoma can make ACTH, SIADH can occur because of the ADH, and it can also be related to Lambert-Eaton via antibodies against calcium channels. So that was the only thing this was really testing you on. That's it. Not much else to really know here. A, B, and C really made no sense whatsoever. So you have to make sure that you remember a patient with lung cancer and calcium alterations, hypercalcemia. That's because of PTH-related peptide coming from the squamous cell carcinoma of the lung. 41. A 78-year-old man is brought to the emergency department by his neighbor because of a 3-week history of severe weakness and fatigue. He has also had a 16-pound weight loss during this period. He lives alone. 78 is really old. Remember, always focus on the age. 78 is really old. He lives alone, says that his daughter usually visits him once or twice a week to bring him groceries. However, he has eaten nothing but small quantities of saltine crackers and black coffee since his daughter left for vacation 1 month ago. He is 5 feet 8 and now weighs 124 pounds. BMI is 19. Pulse is 92. Blood pressure is 108. Physical exam shows generalized muscle weakness. Serum studies in this patient are most likely to show an increased concentration of which of the following hormones. And if you look at everything, right, there's a lot of answers that you can just cancel out, and then cortisol should make complete sense to you. Insulin does not make any sense. Why would insulin be high in this patient? Insulin is usually never high in any patient, right? Unless you have an insulinoma or you have excess exogenous insulin. So B, you can cancel out. Insulin-like growth factor, again, doesn't really make sense at all. There's no reason for this guy to have high amounts of IGF-1. High amounts of T3 would be hyperthyroidism, right? Because of high TSH making a lot of T3 and T4. But this patient is not presenting with symptoms of hyperthyroidism. Like, losing weight is a symptom of hyperthyroidism, but that's not enough to define hyperthyroidism. Other than the losing weight, he doesn't have anything else, right? He shouldn't have weakness and fatigue. In fact, he should have a lot of energy, if anything. And he should be very hungry too, but none of that is happening. So you end up just picking cortisol. The patient is in a period of stress. Cortisol is a hormone necessary for life because it helps manage such situations. He's not eating enough, and cortisol functions in maintaining his blood pressure as well as keeping him alive via gluconeogenesis, lipolysis, and proteolysis to replenish what he's not eating. Right? You notice what he was eating, saltine crackers and coffee. So he's not really getting anything. So where is his lipid, glucose, and protein coming from? His own body, thanks to cortisol. He's breaking everything down, he's losing weight, and he's surviving until his daughter gets back from vacation and gets him his groceries. This is another patient where you would have to give him the questionnaire to see if he has atypical depression, similar to something we talked about in part 1 of this. Now, 42, an 18-year-old boy has just been diagnosed with schizophrenia. His identical twin brother is unaffected, but he and his parents are concerned about his likelihood of developing the disorder. Which of the following best represents the brother's risk for developing schizophrenia? Now, every student I gave this question to pretty much was like, all right, it must be C or E, right? Because the others don't really make sense. Like, you're not actually calculating anything here, so it's not going to be 10, 25, or 75. That would be more of like a genetics thing. Here, it's more like, you know, this is genetics, yeah, but you're not calculating autosomal recessive and shit like that. This is just schizophrenia. Either he's got a half a chance of getting it or a 100% chance of getting it. That's how everyone approached it. While the lifetime risk in the general population is just 1%, it is 6.5% in first-degree relatives of patients, and it rises to more than 40% in monozygotic twins of affected people. Analyzing classic studies of genetics of schizophrenia done as early as in the 1930s, Fisher concludes that a concordance rate for psychosis of about 50% in monozygotic twins seems to be a realistic estimate, which is significantly higher than that in dizygotic twins, where it's about 10 to 20%. So the answer could be 10% if the question was about dizygotic twins. All right, but this, you were assuming these guys are, you know, they're identical twins, so it's monozygotic twins, and that's why you would just pick C, 50% chance. Okay, so that's just a memorization thing that you just have to kind of know. And there's a lot of things related to schizophrenia, by the way. If you actually look at it in the book, and we haven't done it in the new playlist, but schizophrenia is also related to being able to see this. Right, so where do they talk about it? Ventriculomegaly, right, on brain imaging. So you can see how the ventricles look a lot bigger than normal, right? Declining function, everything just comes and goes. There's a lot of things about schizophrenia, but the question that we're looking at right now was related to concordance in twins, which is not really a topic that First Aid talks about. So you want to make sure you understand there's 50% chance in monozygotic twins, about 10 to 20% in dizygotic twins, and 6.5% in first-degree relatives. Okay. 25-year-old man comes to the physician 8 hours after the onset of severe pain of his low back that radiates down his left leg. He started a weightlifting regimen earlier in the day during which he had tried to lift a bar loaded with 200 pounds from the ground to over his head. The pain began almost immediately after his attempt. Which of the following is the most likely cause of the patient's pain? So what must he have done trying to lift something so heavy from the ground to above his head? He must have caused some kind of hernia. That's like the most common thing that can occur from lifting something super heavy without really truly being prepared. And that comes from C, rupture of an intervertebral disc. A fracture of the lumbar vertebra is not going to present in the way it's presenting for this guy. Rupture of the deltoid tendon would again also not present with the severe pain of his low back that radiates down his leg. Right? In fact, this description of severe pain radiating down his leg is sciatica, right? Which is why a lot of people actually wanted to pick D, a tear in the sciatic nerve. Sciatica is not a tear in the sciatic nerve. It's a compression of the sciatic nerve. Right? So common knowledge amongst my family has always been lifting heavy weights will cause a disc herniation. This is something my mom used to say all the time to me. So I just thought of that. But in all reality, the other answer choices can be removed. He probably has a disc herniation at L5 to S1 causing sciatica. He cannot have a lumbar fracture because he is young and there is no indication for a weak lumbar area in him. The deltoid rupture would not cause back pain. The sciatic nerve is very thick and it's not going to tear, but it is being compressed here due to herniation. And a torn muscle in the low back would also not have pain that radiates down the leg. Okay, so if you look at page 498 here, signs of lumbosacral radiculopathy, this is what he's having, right? Shooting pain down the leg, sciatica. Excuse me. So it's the L5-S1 disc protrusion that's compressing his S1 root. Okay, and that is going to cause this kind of pain along this distribution, which is pretty bad. Okay, and that can occur from lifting weights without truly being prepared correctly. You got to wear a very, very tight belt and be ready. And you start with lower weights and then slowly work your way up. 44. A 25-year-old woman comes to a physician 2 days after noticing a mass in her right axilla. She also has a 1-week history of malaise, headaches, and night sweats. The patient says that she recently adopted a kitten and has sustained several bite and scratch marks. Immediately at which point you start thinking of Bartonella. Her temperature is 100 F. Physical exam shows edema and tenderness of the right axillary lymph node, totally fitting Bartonella. The skin over the node is erythematous, tough, and warm. There are scratches and bite marks of various ages over the upper extremities and hands. The result of indirect fluorescent antibody test for Bartonella is positive. A biopsy of this lymph node is most likely to show which of the following histologic patterns. At which point you start cursing everybody because you're like, how would I remember or why would I even know the histologic presentation of Bartonella, right? If you go to Bartonella Hensley in microbiology, let me see. Oh, sorry. This is zoonotic bacteria. Yeah, right there. So this is Bartonella Hensley right here. This is Bart the cat, right? In immunocompromised patients, depicted by the cane, you can get this kind of skin lesions, okay? But in an immunocompetent patient, you're going to get axillary stuff, right? So that's why the dress has those things like that, the lymphadenopathy and all that. And Starry Sky Night, the painting, because of what you're going to see under microscope. And you can use doxycycline, that's why you have a wheel. You can use doxycycline to treat these patients. But nowhere do they really talk about the fact that it's supposed to be granulomatous. Alright, so all the Bartonella information, cat scratch can occur in immunocompetent, while bacillary angiomatosis occurs in immunocompromised. Treatment is doxycycline. And that's really it. Wharton starry silver stain, depicted by Van Gogh's starry night background. Biopsy of the lymph node would show non-caseating granulomas, and this is something that Sketchy Micro mentions, right? But it's not mentioned in the book. It's not really brought up anywhere else. So that's what this question was about, and the answer is B. Granulomas containing stellate microabscesses. That's it. None of the others really mention granulomas, so they're all wrong answer choices. Cat scratch disease, Bartonella infection in immunocompetent hosts, causes lymphadenitis, especially in the axillary region, characterized by sarcoid-like non-caseating granulomas filled with neutrophils. That's it. Okay, so you gotta make sure you remember that. 45 is an ECG question, so I put my favorite ECG image right here too to further explain this. 65-year-old man is brought to the emergency department because of substernal chest pain, nausea, and sweating for 1 hour. He has a 10-year history of type 2 diabetes and hypertension. His pulse is 120 per minute, respiration is 24 per minute, blood pressure is 98/60, physical exam shows JBD. Crackles are heard halfway up the lung fields posteriorly. Which of the following ECG findings is most likely in this patient? And then they pick on different parts of the QRS complex. And you're supposed to go with ST elevation, right? He has a STEMI, ST elevation, MI. Really straightforward, like you don't want to get confused. There's no reason this patient would have QT prolongation. That's usually due to some kind of medication. He wouldn't have QT interval shortening either. PR segment deprivation or elevation is not, depression or elevation is not what you really look at. You look at ST elevation or ST depression, right? Non-ST elevation, MIs, stuff like that. So this man is showing symptoms of an MI, very evidently, right? Sweating, substernal chest pain, crackles, JVD, all of that. The initial phase of myocardial infarction leads to subendocardial necrosis involving less than 50% of the myocardial thickness. EKG at this point would show ST segment depression. Continued or severe ischemia leads to transmural necrosis involving most of the myocardial wall, which is now a transmural infarction, and there you get ST elevation. So when you only have a subendocardial infarction, I've always thought of that as like a depressing injury from the inside. You're hurt from the inside, right? The wall of the heart is actually hurt from the inside, so that's depression. So ST segment depression. Once you have a transmural infarction and the whole wall is broken, that's a really big deal. Things have now elevated, so that's ST segment elevation. The PR segment is usually isoelectric. A depression or elevation should evoke the diagnosis of acute pericarditis if you have something with PR, or atrial infarction, because the PR, remember, was related to your atria, right? The PR segment is depolarization of your atria. QT interval is your ventricular depolarization and repolarization. QT interval prolongation can be due to drugs that predispose you to torsades. Short QT syndrome is an autosomal disorder of the electrical system and can lead to sudden cardiac death if not treated with an intracardial defibrillator. So, none of that really made sense. This was a really easy question. Everyone should have been able to pick ST segment elevation. And other than that, just make sure you know what each part of the ECG is related to, and then localizing it, right? That's the other thing. 46, 3 elderly residents of an assisted living facility in rural Pennsylvania are admitted to the hospital within 3 days of one another because of pneumonia. All 3 patients have a history of chronic obstructive pulmonary disease and returned home from a weekend retreat at a residence hall 4 to 7 days ago. 43 other individuals that also attended the retreat. 2 other attendees developed pneumonia shortly after returning home as well, but they did not require hospital admission. So they were okay. But these 3 guys are not okay. And these 3 guys have COPD. Okay. So the 2 other attendees did not require hospital administration. They were a 37-year-old woman with lupus, treated with corticosteroids, and a 46-year-old man with severe asthma. No other attendees, including 9 children under the age of 5, developed a respiratory illness. None of the other residents of the assisted living facility have any symptoms of respiratory illness. What infectious agent is the most likely cause of these findings? So basically, this entire question stem is simply telling you one thing, that the only people that got hospitalized from this pneumonia were the COPD patients. So now you're coming down to which one of these bugs causes pneumonia that's really bad in COPD patients. And that is Legionnaires, Legionella pneumophila. Legionnaires is actually, the sketchy microimage of it is really good because it's on a ship that really kind of helps you see what's happening. So this, everything on this makes sense, like it's related to Legionella in some way, one way or the other. And generally speaking, it causes salt wasting. You're going to have the diarrhea, the mental, the neurological deficit and all that. On the corner here, this is Pontiac, which is not what this patient has at all. No one got Pontiac. But if they did get Pontiac, that would also definitely cause them to be hospitalized. But generally speaking, the main thing is that Legionella, right? Legionella causes Legionnaire's disease, severe pneumonia, often unilateral and lobar, fever, GI, and CNS symptoms common in smokers and chronic lung disease patients like COPD. So that's what happened to everyone. Everyone got Legionnaire's disease. It didn't cause major issues in a lot of the kids and some of the other patients because they didn't have chronic obstructive pulmonary disease. The one with asthma did get infected, and the one with lupus did get infected too, but they were okay. They didn't necessarily need hospital admission. They were able to fight it off. All right. Of these other ancestors, adenovirus would make all the kids sick and also cause conjunctivitis and diarrhea and many other things. Influenza would also make many people sick. Right? It wouldn't just be these COPD guys. Respiratory syncytial virus would really just cause pneumonia in only infants, so no one would really get sick. Strep pneumonia would also infect many people, including the kids, right? Because the only people that really get vaccinated against strep pneumo are people who don't have a spleen. So the fact that specifically only COPD patients were hospitalized means that it must be Legionella causing Legionnaire's disease. 47. A 56-year-old woman has frequently burned herself while cooking over the past several months. Examination shows loss of pain and temperature sensation in both upper extremities and in a portion of her trunk from the clavicles to just below the nipples. Touch, vibratory sensation, and proprioception are normal. So she just lost pain and temperature. That's literally just, we've been doing neurology lately, right? This patient is losing pain and temperature, which means only the spinothalamic tract is being damaged, and this is a cape-like distribution. Right, only just below the nipples and the arms, so that's going to be Syringomyelia. There is some wasting of the small muscles of her hands. Which of the following findings is most likely on MRI of the head and spine? And you would go with D, a syrinx of the central region of the spinal cord from C4 to T5. Right, and remember that your spinothalamic tract actually decussates in your spinal cord and then just goes up, whereas most of the other guys decussate at the medulla somewhere. So that's a really big difference between spinothalamic and the other tracts you have. And this was a very straightforward question about Syringomyelia. So syrinx, pick D. 48. Which of the following changes in cardiovascular system occurs with normal aging? Which is a really commonly asked question. And UWorld has this really nice diagram to kind of help you see a young heart versus an old heart. Right? And you can see that in an old heart, you would have your dilated aortic root, sigmoid-shaped septum because it just got thick, decreased left ventricular cavity size, almost looking like hypertrophic cardiomyopathy, and enlarged left atrium because it's contracting really hard to fill the hypertrophic cardiomyopathy. Shortened base to apex dimension. Alright, so now you look at all your answer choices, and the only one that fits is D. Increased basal systolic blood pressure. Right, your systolic blood pressure is going to be a little higher with normal aging. And this was a really interesting way to test this because this answer choice is not something that's directly written in this image or anything like that, right? But if you look at the other answer choices, things that occur with normal aging, development of coronary atherosclerosis is not something that occurs with normal aging. That occurs to someone with normal aging if you have really bad diets, but it doesn't occur to everyone. It's not something that occurs to everybody. Mitral stenosis, again, not something that occurs to everybody. That might be related to someone who might have had acute rheumatic fever when they were younger. The mitral regurgitation, as they age, becomes mitral stenosis. An increased basal heart rate, there's really no reason for your heart rate to increase as you age. Increased cardiac muscle mass was actually a really unfair answer choice here. I'll be honest about that because you can see the increased cardiac muscle mass in the picture here. But that's not correct. I'm trying to remember what I had read about that. I forget why this one was wrong, but because increased cardiac muscle mass, basically that's talking about the whole heart, whereas really you're only going to have increased muscle mass in the ventricles in the inside, not the outer portion. It's not that the heart is getting bigger or more muscular, but it's just a little bit of mass increasing in the ventricles. That's it. Not the atria though. The atria don't necessarily get more muscular. Alright, so muscle mass doesn't necessarily increase in that way. And the last answer choice, increased compliance of arteries. That's false. You're actually going to have decreased compliance of arteries, right, as you age. And that was really it. So the only answer choice that they really should not have put here was E, increased cardiac muscle mass. And that's it. '49. So 49. A 28-year-old woman of Eastern European Jewish descent comes to the office 2 days after she noticed a lump in her left breast. Her maternal grandmother was diagnosed with ovarian cancer at the age of 54 and died at age 60. Her maternal aunt and mother were diagnosed with breast cancer at the ages of 36 and 40, respectively. The aunt died as a result of the disease at the age of 50. The patient is concerned that she may have inherited a genetic mutation that would predispose her to breast and/or ovarian cancer. Genetic testing of this patient and her mother are most likely to show a germline mutation in a component of which of the following pathways? Right? Now, you need to remember the difference between BRCA and HER. Right? BRCA and HER are two main guys related to breast cancer. BRCA gene mutation leads to defective homologous recombination. BRCA involves the breast, ovaries, and pancreas, while HER2 involves the breast and the stomach. BRCA1 is usually the culprit, although in men it's usually BRCA2 mutations. HER2 is an oncogene, turn her on is a way to remember that, while BRCA is a tumor suppressor. Okay, so that's, 49 is just going to be E. If you are studying for step 1, one page that you should have printed out on your hands is this thing right here, oncogenes versus your tumor suppressors. Right? And I've already done the video on this thing, but under pathology. But the main thing is you really want to be able to remember all of these genes in relation to what they cause, and whether it's an oncogene or a tumor suppressor. And some of these are much more high yield than the others are. So for breast cancer, I always remember to turn her on as HER2 being the one that causes oncogenes, and it's breast and gastric carcinomas. Right? So, women love to eat, and I always think of 2 ways to turn her on is either play with her breast or feed her. So that's just a funny way of remembering that correctly. So HER2 is related to breast and gastric carcinomas, whereas tumor suppressor, right, BRCA, this is BRCA, breast, ovarian, and pancreatic cancer. So not the hardest thing because there's no overlap. There's no gastric stuff here at all. It's really just pancreatic cancer, but no gastric cancer. So the two differences are often tested, and you got to make sure you know what you're talking about because the genes that cause them are very different from each other, right? So this one is the recombinational double-stranded DNA break repair. You can't do it anymore, right? Because with DNA repair, protein is the gene product of BRCA. Last question for block 1, 50. A 50-year-old woman with a restrictive pulmonary disorder with no obstructive component is most likely to have which of the following sets of pulmonary volumes? Really easy question. You have to remember that in restrictive, everything is down, so the only answer choice that has everything pointing down is A. Your functional residual capacity decreases, your residual volume decreases, and your vital capacity decreases. And more difficult than this is actually remembering the loops rather than, these loops, right? You have to understand how these loops work because these loops are very unorthodox. Normally when you have a graph and an x and y axis, this is your the y axis, right? The y axis is usually on 0, right? Like that. So you can see what's happening. Things are going further away from the y axis, so they kind of shunted. They redrew the axes in a whole different way, and that's just first aid and step 1 trying to be smart on you. But the main thing here is and look at the way the numbers are going. Like, why couldn't this just be 0, 2, 4, 6, 8 and have it like much more normal? But it's not like that because there's two things you're seeing here. You're breathing in and then you're breathing back out. That's why it's a loop. So breathing in and then breathing back out. And it's really important to understand the difference between all the different things. And in your restrictive guy, your loop shifts to the right. Right? So if your loop shifts to the right, everything decreased. Everything decreased because you're going to smaller numbers. That's just the way the graph is made. And it's pretty fucked up if you ask me. They should have used a pretty standard graph with 0, 2, 4, 6, 8 in the right order and everything just making much more sense. But now you have to remember that the loop shifts to the right because the numbers are backwards and the numbers actually get smaller in a restrictive lung disease. See, everything goes down. Everything goes down. Whereas in obstructive lung diseases, a lot of stuff gets stuck. There's air trapping. Air trapping means your residual volume increases, your FRC is high, your TLC is high. So that's the main difference that you want to make sure you get right. And that's it. So now, the next time I am live to do NBME, I'll continue on into block 2 of NBME 20. Thanks a lot for joining, and I hope this is helping.